under general anesthesia. After all, the pleura is violated, the lung is manipulated, and it makes sense that the anesthetic technique used should be able to provide a quiet surgical field, an excellent view of the lung, and protect the patient's airway. But what of patients who are deemed high risk to undergo general anesthesia? One in whom not just one hemithorax but both are for surgery. Is there an alternative that could provide equal if not better outcomes? So good afternoon, my name is Anna Chua and I am here to say that yes, there is an alternative and yes, it will provide better outcomes. I will be presenting a case of bilateral non-intubated VATS deloculation under bilateral surgical paravertebral block. Our patient is a 48-year-old male who came into the ER for difficulty of breathing. He had pleural effusion just 1 month before and was sent home with bilateral draining pigtail catheters. While at home, however, there was less and less output draining and more difficulty breathing. Physical exam revealed decreased breath sounds and O2 saturations of 94% on room air. Ultrasound done for this admission showed 1,000 ml of loculated effusion. Hence, the patient was scheduled for bilateral VATS deloculation. The patient also had poorly controlled hypertension, insulin requiring diabetes, chronic kidney disease, anemia of chronic disease, and an 18-pack-year smoking history. He also had lower thoracic spine surgery just the year before. Labs confirmed anemia and imaging confirmed pneumonia. Based on ARISCAT scoring, the patient was deemed high risk to develop post-op pulmonary complications. So given the current situation and with a capable anesthesiologist on hand, the plan was thus to perform a surgical bilateral thoracic paravertebral block. So the patient was wheeled into the OR, supine, awake, and calm. He was hooked to standard non-invasive monitors with the following vital signs. Oxygen mask at 6 liters per minute was placed. Midazolam and fentanyl was given for sedation before placing an arterial line. Meaningful contact was maintained. The patient was then placed in the lateral decubitus position. The T3, T5, and T7 paravertebral spaces were identified using ultrasound, appearing as a wedge-shaped hypoechoic layer just caudal to the transverse process. A needle was advanced until target area was reached, and saline was used to check for proper placement. This was confirmed then by anterior displacement of the parietal pleura. 5 ml of levobupivacaine, 0.5%, was injected into each space, and the same was done on the contralateral side. The patient was then returned supine. Propofol target-controlled infusion was started to maintain the patient comfortable and asleep, but spontaneously breathing on a face mask, maintaining O2 saturations of 99 to 100% for majority of the procedure. Vital signs ranged as follows. So the procedure done was a bilateral VATS deloculation, pleural biopsy, talc pleurodesis, closed tube thoracostomy, JP drain insertion. Used then transferred asleep and without complaints of pain to the recovery room with stable vital signs and 100% O2 saturation. Now, there are always two sides to a coin, and it's true that the procedure could have been done under general anesthesia. The benefit of GA is a collapsed immobile lung, giving greater ease in palpation of masses, access to the mediastinum, and superior visualization. However, there are also risks, such as ventilator-associated lung injury, intubation-related trauma, and the effects of neuromuscular blockers and so on. So a resurging alternative is non-intubated, awake VATS, the goal of which is to create an iatrogenic pneumothorax and subsequently a collapsed lung while maintaining sufficient spontaneous ventilation, thereby avoiding your complications associated with general anesthesia. Awake VATS is used in numerous procedures, but particularly in pleural effusion, patients tolerate the surgical pneumothorax well due to the chronically collapsed lung. During VATS, the surgery creates a pneumothorax resulting in paradoxical respiration. During expiration, gas flows from the lung in the closed hemithorax to the lung in the open hemithorax, while the reverse occurs during inspiration. The loss of negative intrapleural pressure in the open hemithorax results in contralateral mediastinal shift with compression of the dependent lung. Therefore, there are risks of developing hypoxemia and hypercapnia from the paradoxical respiration and hypotension from mediastinal shift. However, because the patient is awake, diaphragmatic tone is maintained, which reduces the respiratory compromise. So another concept to discuss here is hypoxic pulmonary vasoconstriction, or HPV, and whether awake or under GA, the collapsed lung continues to be perfused without ventilation, causing a right to left intrapulmonary shunt, leading to hypoxemia. HPV is a mechanism that prevents this shunt, constricting your pulmonary arteries and redirecting blood flow to alveoli with richer oxygen content. Certain anesthetics such as gases inhibit HPV. On the other hand, awake VATS preserves HPV, whether with or without sedation. So in our case, oxygenation was adequately maintained for the duration of the surgery. Despite this, however, it is still necessary to be prepared to convert to general anesthesia should the need arise. Awake VATS is typically associated with a thoracic epidural. Benefits to this include the following, such as decreased post-op cardiac events and better pain control. However, a thoracic epidural also puts you at risk for the following. So another alternative that we can have is actually a thoracic paravertebral block. So this involves the injection of a local anesthetic in the paravertebral space where the spinal nerves emerge, resulting in ipsilateral somatic and sympathetic nerve blockade and multiple contiguous dermatomes. Contraindications to a paravertebral block are few and are similar to a neuroaxial anesthesia. Compared to a thoracic epidural, a paravertebral block guarantees similar analgesic efficacy, but with fewer complications. So there are less pulmonary complications, less urinary retention, less nausea and vomiting, less hypotension, less failed blocks, while at the same time providing no difference with analgesia. But can the block be done bilaterally? Studies have shown that bilateral thoracic blocks have good results with few side effects and no serious complications. There is potential risk for pneumothorax, eightfold actually, but given the type of surgery done in pleural effusion, this did not present to us a problem. Larger doses of local anesthetics are necessary, but there have yet to be any clinical reports of local anesthetic toxicity. Nonetheless, we used levobupivacaine, and as was done in this case. Hypotension was found to be uncommon, even under bilateral block. Measures must still be taken to improve lung function, such as chest physiotherapy and incentive spirometry, early mobilization, and adequate analgesia. In our case, IV oxycodone was used and discontinued 4th post-op day. Paravertebral blocks are capable of providing surgical anesthesia, provide post-operative pain control, and should be used more frequently in thoracic surgeries. Thank you.